So I would like to give you all an overview of the iris claw technique. And as already discussed by the previous speakers, the indications are almost the same when you have a patient with aphakia, failed IOL, when the IOL is not stable in the eye, or when there is subluxation of the lens, you plan it as a primary procedure. And again, secondary implantation as well. So you have the two types of doing it, either the anterior chamber fixation or the retropupillary fixation. We prefer doing the retropupillary fixation since it's safer, it's easier to do, and also is less traumatic to the corneal endothelium. So a little about the specifications of the lens. It's a single piece PMMA lens, and the overall length is about 8.5 millimeters, and it has two flexible claw-shaped haptics. So this is a haptic with an opening in the center. So that is what laws to the iris. Again, preoperative preparation is selection of anesthesia for the patient. Preferably do it under subtenons anesthesia. Biometric calculation is like any other PCIOL, but we would like to go about 0.5 to 1 diopter lesser in comparison to what we would usually place in the bag. Again, it is good to have a thorough ocular examination, mainly to see if the iris is healthy, if the iris claw can be enclaved in the iris. Again, you also have to look for any complications like glaucoma or uveitis, which are a contraindication for iris claw IOL. The other thing is, again, as Shivkumar sir was mentioning, look at the corneal endothelial counts. So that is also important when you plan for any kind of secondary IOL surgeries. Contraindication again is inadequately constricting pupil. In case of traumatic mydriasis, you have to have a fairly good pupil and a good iris anatomy to do this procedure. Any distorted pupil, iridotomies, or iridodonosis floppy iris are all contraindications for doing iris claw IOLs. So what you need is a Clayman forceps, as Sir rightly mentioned in his talk. Again, this is the iris claw that we use from Excel Optics, and a good vitrectomy machine is mandate. You need to do a good vitrectomy as discussed by Dr. Navneet. The surgical steps are relatively simple. So one is you create your incision. And that is, you can do it either superior or temporal. Again, you can plan the incision to correct the astigmatism that is present preoperatively. Vitrectomy, a good vitrectomy, and a peripheral iridotomy. So all these patients, it is good to do a peripheral iridotomy on table, or you can even, if you're planning it as a secondary procedure, then you can always do it even prior to your surgery. Pupil management, again, you in intracameral pilocarpine is a good way to constrict the pupil. You want the pupil to be as small as possible. Again, once the IOL is inserted and enclavation is done, always ensure that your wound is closed at the end of the surgery to avoid getting any infections. So these are patients that are planned for iris claw on table when you do not have adequate support. So you make two incisions. So here the surgeon has already made one incision previously. So you make two incisions opposite to each other, preferably at 3 and 9 o'clock. And you can use either a Sinski or a spatula to tuck the iris. So what you do here is you hold the lens using the Clayman forceps. One tip here is as you're holding the lens, you can actually make sure that it is close, it is in the same line as your iris claw. So in that way, you get an idea as to where you have to tuck your iris. And the other thing is do not go entirely into the behind the pupil. In that case, there is a high chance of you dropping the IOL. So what you do is, as in this case, tuck one side, make sure that the optic remains on the pupil margin. And then when you're doing the other side, you can shift hands, hold the lens, and then insert it into the behind the pupillary margin, and then you can tuck your iris. A good vitrectomy pre and post lens placement is good. And again, this vitrectomy will also help remove all the OVD that you have actually injected into the vitreous. A good vitrectomy is a must. Otherwise, this can cause a pupillary block in the post-operative period. Then you hydrate the side ports and make sure that you suture the wound. Yeah. So this is another patient with a traumatic subluxated lens. Once the nucleus is removed, you see that the pupil is relatively good here. Sometimes you can have a very irregular pupils due to chronic inflammation. It can be thickened. So all this can cause an issue when you want to place an iris claw lens. So here I'm using tricot to give me better visualization of the vitreous, doing a good vitrectomy. Once that is completed, I'm doing a PI here. So keep your cutting rate as slow as possible. And you can use the IA cut mode to create a good PI. So PI is mandate to prevent any pupillary block and increase in pressure. So your PI will take care of it. So one thing I do is to ensure that the claw opening is good, because we've had incidences where we've gone inside and then we've been struggling to open up the claw opening. So just ensure that it is open, but be very gentle because you can break the claw. Again, when you enter sideways, then go in. So if you actually look, I'm holding it at a point where I know this is the point where the iris will enclave into the claw. So I just hold it there. So keeping the lens on the iris actually gives me support. So there is no dislodgement into the vitreous. So then I again go in with the other hand. I switch hands and then enclave the iris again here. So you can use a needle, you can use a spatula, you can use a Sinsky, whatever you're comfortable with. I prefer using a spatula. I like to suture my wounds. And again, to avoid cat's eye, the one thing that you have to do is go slightly away from the pupillary margin. So if you're going to do it closer to the pupillary margin, you're going to have a cat's eye pupil. Slightly in the mid periphery will avoid giving you a cat's eye pupil. So this will be the outcome, and you can see the enclavation here. So you'll see a dimple. So you'll hear a click when you're operating. So when you actually tuck it, you'll feel it, and you can kind of feel that click. So then you know that your iris is stuck into the claw. And you'll also see a dimple. If you increase your magnification and focus on that area, you will see a dimple. So you know that your iris is enclaved in the claw. So this does not affect any pupillary dilatation. You can obviously dilate these patients once you've done the surgery. So some intraoperative complications that you can end up with is bleeding from the iris root or iridodialysis. When you put too much of pressure on the iris, you can tend to pull it away from the root. Again, IOL drop that can happen. That is why you place it on the iris margin or the pupillary margin to prevent it from dropping behind. And again, DM detachments at the side ports. So when you go through the Sinsky and all that, make sure that you go sideways and not just directly, so that you can, when you go directly or when there is a resistance there, you can always end up having DM detachments. One thing that you can do as a beginner is to mark your side ports. You can use the blue ink marker and mark your side ports so you know where exactly you have to insert your instruments and then tuck your iris. Again, the cat's eye pupil that I was describing about. So this is when you're going to have the iris claw tucked here at the pupillary margin, you definitely will have a cat's eye pupil, but going away from the margin. And the other thing here is to make a shorter stab incision, not a long corneal incision. If you're going to have a long corneal incision, again, instrumentation is difficult, and also your tucking will invariably happen closer to the pupillary margin. So have a shorter incision. The two side ports that you're making should be shorter. and closer to the limbal margin. So post-op complications, as already mentioned, ovalization of pupil. There can be, cases where there is de-enclavation and dislocation of the IOL into the vitreous, endothelial cell loss, and obviously cystoid macular edema due to all the inflammation that's being caused. So the advantage of this procedure is that it's a sutureless procedure. Again, reduced invasiveness, faster surgery, and the learning curve is relatively easy in comparison to the other forms of secondary IOLs, where there is definitely a learning curve. This is relatively easy. So any good anterior segment surgeon is able to do this procedure with much ease. So to sum up, it's a good alternative in cases with inadequate capsular support. As already mentioned, there's a short learning curve. The surgical time also is not much in comparison to the other procedures. And there is good refractive predictability and also repeatability. Thank you for the opportunity.